clinical judgment.
Okay. That is a good point.
Sir, only we specially send them whenever we need to start oral steroids. And in other cases, they never say no, sir. They say it's your judgment.
Okay, that's
they write
so. It is bad.
Right.
It is not a good idea to start on your own. Send the
no,
patient to a.
Never, sir. We never start.
That's good.
Always
Thank you. But very nice presentation. Very good. Very good.
Thank you, sir. Thank you, sir. Sir, one question, sir. Dr. Tuli is here.
No.
Dr. Tuli, are you here?
Chalo, okay. To the panelists, all. Sir, sometimes we get patients who have a glaucoma-like optic atrophy, and their IOP is almost normal. They say it's a normal tension glaucoma, and these patients have been put on anti-glaucoma drugs for last many years. Sometimes I think that the drug should be stopped. What should be the next line of action?
But you are saying that the patients. The optic nerve is being damaged not because of the glaucoma, because of the IOP.
Yes, sir. The cup is very shallow, but for last many years they are putting IOTIM or any other.
Even then they are losing the eyesight.
No, same. There is no progression. They don't have any record of progression also. But
so it's very good query. It's very good query. It's excellent. I have faced this kind of situations. The problem now lies if somebody else has prescribed the medicine somewhere, some other hospital, and if you stop it, and patient loses vision because of some other reasons, so they will always held you responsible that it was a kalamoti and you told and I have lost. Basically, I will try to suggest if the medicine is not doing any harm, some systemic side effect or something, So there's no, the things are very, changed so much in today's scenario. You have to be self-defensive. You are very right. You are very right that you can stop the medicine if it is not a glaucoma. But then you can ask the patient to undergo various like MRI and a systemic examination complete. And you have to explain. But suddenly we should not stop. We should always ask the patient to visit us again and again. And then, counseling and again and again that you are not having glaucoma. There's a primary optic atrophy, so you can have a consultation with a neurophysician also.
Thank you, sir.
That's my
first in the confusion where there is a suspicion of glaucoma, we usually take the second opinion from the second ophthalmologist, whosoever is nearby, and we always discuss that should we start or drugs or not. So since phone are there, and we usually do, I send my patients to medical college. Usually send these patients to PGI Chandigarh, and lots of patients came back there. They said there is no glaucoma in your eye, but they were the primary suspect. So it's a better technique. If there is a suspicion, you suggest think of that this is a glaucoma, and your diagnosis is just near. Then you should always send it a better center where the proper diagnosis can be made, and after discussion the patient can be followed. One thing I do more, we usually okay.
Yes, you are audible.
हाँ, we usually एक कॉपी बना लेते हैं हम लोग, सिंपल जो स्कूल में आती है, और उसमें we usually write keeping drugs and IOP, OCD, so that we can follow that patient with that booklet to what to do next. Otherwise, in the government sector, we don't have electronic setup, so we can save their data on computers, or on the time of the next visit we can see that data. But we are doing this for any person who is suspicion or having glaucoma. We keep a booklet for them, and we write all the medicines and notes on the that booklet. So we can also, to others fellows being also can do. They can also keep a small diary or copy बोलते हैं, notebook.
That's very good suggestion. That's very good suggestion, Dr. Durki, because what I feel, once we diagnose a glaucoma, and the second opinion is very good because of the legal, these things, and whenever the doubt is there, and making a copy, or what we do is, there one person is dedicated, he calls that particular person who is on drugs. You should come back, and we explain in very layman language. I explain to the patient. A lot of, counseling has to be done, teaching has to be done to the patient. He should know what glaucoma is. I give example. There is a bulb and there is a switch. In between, the wire is broken. So you change bulb or you change the switch, the light is not going to go on. But in electricity, you can change the wire, but inside the body, the optic nerve, if it gets damaged, then it may be optic nerve of the mightiest person or the richest person. We cannot bring your vision back. So I do agree, and HPS should work on this. Enough is done on cataract. Patients are having a lot of awareness. Nowadays, we find very few cases of phakomorphic or this kind of glaucomas. But still, we are losing eyesight of patients because of glaucoma. And the problem is only the, sometimes diagnosis, sometimes, most of the time, not giving enough time to the patient. But if you counsel the patient, if you teach the patient, you show them videos and on animated videos or on the models, they do understand, they undergo treatment. And you are very right. I suggest all the members to have a second opinion in case of a doubt, and sharing is really caring if you want to do something good to the society through our HPS. That is my message.
Thank you, sir.
It's a very good message. Dr. Anil, you want to add?
Dr. Rohit, very good presentation. You have shown a very beautiful and educative videos. Nice, but your talk was
did not have enough time for that. I had the full videos to go on, but maybe some other time. Okay, just one small thing which I would like to add to what our wise doctors have said regarding this glaucoma, your query. I have been in close contact with PGI, and they have a set protocol for such patients, because when we send them patients or somebody else sends them, more than half of them are not glaucoma. So according to them, first of all, is a very good evaluation of the optic disc. And as even Dr. Tulip said, you have to ascertain whether it is glaucomatous optic atrophy or not. So that has to come out of experience. So there is a set pattern of glaucomatous disc changes, how you can diagnose. And number two is you have to document it. Document as a photograph also, and also as OCT or as visual field loss. And when you have a reliable visual field, then even if you stop the medication, you should not tell the patient that you don't need it. You have to call the patient after about 1 month of washout. Exactly. What we say, we tell them not to put on, we tell them ki you may or may not need the glaucoma medicine, but we have to make sure, because today your pressure is normal. To me, your eye seems normal, but still that person who has started your medication must have a good reason to do it. So please come back to us after 1 month. We will reassess the intraocular pressure. And if it is normal, then you can continue without medicine. But then after 6 months, you have to come back and do your visual fields again. And that would even make it more sure whether stopping the medicine has deteriorated his visual fields or not. So only after consecutive 2 or 3 visual fields, you can tell him that you do not need any treatment for a glaucoma. Because it is not very easy for everyone to say whether this is glaucomatous optic atrophy or it is due to something else. So these 3 things, once this documentation is done, then as Dr. Mahajan said, then nobody can challenge you that you did not give me the proper treatment, because you have the record that your pressures were normal, your visual fields were stable, and that is why we stopped you. And the IOP was within the normal. So that is the basic thing what we do here.
Great.
I want to add in this.
I'm here to thank you all.
Sir.
Yes.
All the speakers. Dr. Rudki and Dr. Sandeep Mahajan for the nice presentation and discussion. And we got the time and we discussed elaborately on all the topics. Thank you. Thank you very much.
Thank
Thank you,
you.
sir.
Bye-bye. Bye-bye. God
Bye,
bless
sir.
you all.
Bye.
God bless you all. We should have a physical meeting now. We
Yes,
should have a
yes.
physical soon.
एक
Sir,
बार ऐसा है, सुनो,
actually,
सुनो,
the
सुनो.
next HPOS meeting is scheduled to be in Kangra only, district Kangra. So we can
Okay,
start
okay.
planning. All the people in Kangra and
Dr.
Hamirpur
Soni,
should start thinking.
Dr. Soni
Sure,
sir,
sure.
Dr. Soni,
We
Anil, Dr.
will
Anil is
welcome
also
that.
here.
You
अच्छा, Dr. Soni चले गए अब.
take all the precautions and plan it by
Yes.
the end of the year.
Yes, sir.
Let us hope COVID goes away permanently.
Sir, meeting ही कर
Yes,
लेते हैं.
inshallah, sir. Inshallah.
Sir, meeting ही
चलो
कर
जी,
लेते
bye-bye.
हैं.
Bye-bye.
Bye, sir.
Bye.
ठीक है sir, okay, okay.
Thank you.
Thank
Thank
you.
you.
Bye, Rudki. Dr.
Bye,
Rudki.
sir.
Bye. God
Okay,
bless
okay,
you.
sir.
Thank you, Dr. Mahajan.
Okay, ji. Bye-bye, Dr.
Okay,
Saab.
sir, okay,
Bye.
okay. Okay, doctor.
Bye.
Thank you,
God
Dr.
bless you.
Rudki. Okay, bye.
Okay जी, bye bye.
Hi, good evening. You need to unmute yourself. We will start sharp at 7:30, which means we have 8 more minutes to go. We'll wait for a few more panelists and then we should start sharp at 7:30. Thank you all for checking in early.
Hi, folks. How are you, Rick? Aaron?
Good to see you, Jeff.
And you? Yeah, all different times. You're early morning, aren't you, Rick, at the moment?
About 9 o'clock.
All right. And Aaron, you're about 11? 10. Mid-afternoon. The sun is shining. I don't know who's chairing the meeting or this section.
Very good evening, everyone. We can begin the session now. It was supposed to be from 7:30. So before we begin the session, I would like to introduce our eminent speakers and panelists to everyone. So our chairpersons today are Dr. Usha Kim, who is the head of Department of Orbit Oculoplasty and Ocular Oncology Services at Arvind Eye Hospital. And presently, she is the president of Oculoplasty Association of India. She has started a new innovative, which is Ring of Hope in 2004. And in addition to her co-clinical work, ma'am is also involved in the key leadership positions at Arvind Eye Care Center. Coming to our next chairperson, Professor M.S. Bajaj, who heads the Oculoplasty and Ocular Oncology Services at the Apex Institute of the country, that is Dr. Rajendra Prasad Center for Ophthalmic Sciences, AIIMS. And he's involved in clinical teaching and research work, and his research work mainly focuses on the superspecialties of lid, ocular edenexa, and orbital and lacrimal disorders, which include evolving newer and more innovative surgical techniques. Next is with us today, Dr. Mukesh Sharma, Jaipur, and specializes in orbit, ophthalmic plastic and reconstructive services. He is currently the secretary of Oculoplastic Association of India and has won numerous awards and has participated in various scientific deliberations at national and international conferences. We have also today with us Dr. Rachna Meen, who is the Associate Professor, Oculoplasty and Ocular Oncology Services at RP Center, AIIMS, and has over 100 publications. We have a young dynamic oculoplastic surgeon with us, Dr. Nair, who is an internationally recognized oculoplastic surgeon, author, and speaker with over 100 peer-reviewed scientific publications and has authored over 15 chapters. Coming to our eminent speakers, we have Dr. Arun D. Singh, who is the director of ophthalmic oncology at the Cole Eye Institute Cleveland Clinic, and has more than 450 publications and has edited a major textbook that is Clinical Ophthalmic Oncology, 6 volumes, and is currently the editor-in-chief of Ophthalmic Oncology and Pathology Services. We have Dr. Richard C. Allen. I think every young oculoplastic surgeon who is starting his surgery has seen Sir's videos. He has edited and narrated over 300 oculoplasty surgery videos, which are all there in YouTube, and they're of really great help. Sir has several publications and is the professor oculoplasty at Baylor College of Medicine, Texas Children's Hospital, and MD Anderson Cancer Center. And then last but not the least, we have with us Dr. Rose. Professor Rose is the consultant orbital of lacrimal and plastic reconstructive surgery and has been the past director of the Edenexel services at Moorfields Eye Hospital. He has more than 300 publications on the Edenexel disease and has held several important positions in the British Oculoplastic Surgery Society and European Society of Ophthalmic Plastic and Reconstructive Surgeries. Sir has numerous publications as well as numerous awards to his credits. And I am Dr. Gunjan, a practicing oculoplastic surgeon and an ex-senior resident of Dr. Rajendra Prasad Center for Ophthalmic Sciences. So a very good evening to everyone. And now we can begin the session with Dr. Arun D. Singh, sir.
So you need to unmute yourself.
Unmute, share screen.
I am trying
I
to.
got it. Well, thank you so much, first of all, to invite me to participate. I can see eminent speakers, Dr. Allen, Jeff Rose, everybody knows them, so I'm really, really privileged to be part of this special group. So everyone treats retinoblastoma in major centers in India, and India has the largest number of cases of retinoblastoma in the world, so everyone kind of is familiar with what's going on. But I want to give a kind of very broad perspective, and the title being, Are We There Yet? I am from Kola Institute Cleveland Clinic in Ohio. And when you talk about are we here now or are we there yet, you really have to see how the whole treatment has evolved to get like a trend or perspective over a long period of time. And of course, we're going to focus on challenges and present solutions and what might be in the future. So in a very broad perspective, the first definitive treatment for retinoblastoma goes back to 1850, and that was enucleation. And 1850s is just about when ether and chloroform became available for general anesthesia in 1842 and 1847. So I can imagine enucleation being very challenging in a child before anesthesia. So 1850 is the first definitive therapy. And so if you were practicing in ophthalmology in 1860, you will be promoting this new revolutionary treatment for retinoblastoma. And then it took almost 50 years. In 1903 was the first case of external beam radiation treatment for retinoblastoma, which actually went on for almost 100 years. And before we realized, or well, towards the end of it, we came to know that there were major complications, not so much of deformity and loss of vision and dry eyes and cataracts, but of second malignant tumors in children with germline mutations particularly. And so that kind of faded away and took us towards the realm of chemotherapy. So if you're an oncologist like I am, if you look at how do you manage cancers, well, surgery, radiation, chemotherapy. In retinoblastoma, it seems to be sequential evolution, so nothing very surprising here. And so the chemotherapy came about way back in late 1990s, and its credit goes to Judith Kingston from St. Bart's, who promoted chemotherapy for retinoblastoma, and that is intravenous chemotherapy. And then we kind of moved in 2010, almost 10 years ago, to intra-arterial chemotherapy. And between these two methods also came along the intravitreal chemotherapy that seems to overlap the trend of intra-arterial chemotherapy. So there is, the way the treatment has evolved itself has led to some skewness of data, the way it's reported and analyzed. So if you look at the overlap a little bit more detail, IVC came earlier on, IAC came more recently, and intravitreal chemotherapy kind of overlaps more so with intra-arterial chemotherapy. So most of the data that we see now is actually a combination of IAC and intravitreal chemotherapy, rather than intravitreal chemotherapy and intravenous chemotherapy. So the way the data is analyzed, it kind of favors or exaggerates the outcome rates of intra-arterial chemotherapy. And why are we using more localized ways of giving chemotherapy? Because you want higher levels. You get higher level in the eye as compared to plasma with intravenous, and more so, of course, with intravitreal chemotherapy. The idea also being to reduce the systemic toxicity, but at the same time, you increase ocular toxicity. So toxicity hasn't disappeared, it just has shifted from systemic things like neutropenia, thrombocytopenia, etc., to more like ophthalmic retinal artery occlusions, which can cause blindness. So you can recover from thrombocytopenia, but you cannot recover from ophthalmic artery occlusion. So some of these complications are extremely damaging when you're trying to save the vision, essentially, and you could have an eye but has no vision. So this is the kind of the balance and the debate about going on. But again, intra-arterial is not necessarily very new. It's just been more popularized for the last 10 years. The credit actually goes to Koniko and Suzuki from Japan, and they go back to 1986, so almost, 25, 30 years. And the idea being to catheterize the internal carotid artery and just kind of reach the ostium. And when you inject a dye, you can recreate the ophthalmic circulation here. So that's not very difficult to see what you are getting here, but the process is rather tortuous and complicated. You're starting from way down from the femoral artery and pushing the catheter up. And to get to this point, you really need this huge setup, almost there's like a fluoroscopic suite. And we say, where is the eye and where is the patient? Well, the patient is kind of right here and the eyeball is kind of right there. So you need this huge setup. You need a lot of expertise. You need an expert, a neuroradiologist. You need like a fellow. You need a nurse coordinator to put it all together. It's time consuming. It's very it's very expensive also. So when you compare IVC with ISE, IVC is widely available, cheaper, etc., and ISE needs a lot of expertise. And cost is particularly important when you think about where the retinoblastoma happens. 90% in Asia, in African nations, and kind of low to middle income countries. That's where retinoblastoma is. And most of the death from retinoblastoma globally also happens in these countries. So you can think about treatments that cost $200,000 or more, etc. It's kind of impossible to deliver in a broader perspective. So these are the challenges. So challenges are late diagnosis, access in areas where retinoblastoma happens. This is a slide shared by Chawla from Delhi, from All India Institute. Okay, these are the kind of patients they have seen. Not very commonly, but once or twice a year, you will see a case like this, and this shows up in All India Institute. It's like, why is this child in this state? There are many reasons for it, of course. Some of them are cultural barriers, but more so also is the lack of access to regional care. Nobody can travel 1,000 kilometers to get to the nearest specialized center. It's just not possible. Cost, income, etc. You understand all those things. So you really need to find solutions from the public health perspective. You need to have more centers beyond big cities. You need to have health extenders and all the things that go along with that. So you really also need to look at the outcomes. Everybody is this like in the hype. I want to do the latest treatment. I want to do the latest treatment. Nobody knows what actually happened to the child. Nobody knows that the father had to, loan his house to get the money, and the mother couldn't come, and the child died in some place far away from the village that they came from. So there are a lot of social, economic, huge burdens on the children, and we don't seem to capture that essence. It's not the destination, it's the whole journey of treatment that's a burden. An average number of anesthesias required for a child having conservative therapy, intravenous or intraarterial, is about 30. So a 1-year-old child for the next 3 years, every month of his life for the next 3 years is going to have examination and anesthesia on average. That's a lot of burden. No matter, even if you try to get to the treatment, think about every month you got to show up in the hospital. So what people are trying to do, well, there are a lot of effort going on from a global perspective. I really want to give credit to Didi Fabian from Israel, who's tried to put like a global retinoblastoma project, trying to get data from all the centers in the world. People are trying to make electronic or telemedicine pathology labs, so the samples can be read and the high-risk features identified. This is a credit to Hans Grosner-Klaus from Emory. And then, of course, within the US, we have a children oncology group, which has taken over some of the guidelines for retinoblastoma management. They conduct all trials for leukemias and lymphomas in children. They also have incorporated retinoblastoma within the trial. So there is some kind of data or national guidelines, let's say, or some kind of national protocols and studies being developed within the US and, of course, in other parts of the world. So the question is, are we there yet? The answer is very simple, not really. So although we have made these high-tech innovations in delivering a very specific or local therapies, trying to minimize systemic toxicities, we still are burdened with local toxicity. Some of it is drug-related, some of it is technique-related. So we have to sort that out. But I think the bigger challenge really is this public health approach if you want to think about retinoblastomas. Only 250 new cases of retinoblastoma happen in the US every year. Whereas in India, you're talking about 2,500 or maybe 3,000 cases. So think about, what works in US is not going to work in India. They're two different countries, two different systems, economies, and all the different things. But in any case, we are not there yet. We really need to focus on both aspects, not just the high tech, but also the public health. And I think public health perhaps is a bigger challenge. Thank you so much.
Dr. Gunjan, do we have time for some questions?
Yes, we do have, sir. Thank you, sir, for that wonderful talk on retinoblastoma. Definitely, we are not there yet because there are a lot of issues in administrating intra-arterial chemotherapy also, and we do have logistic issues, especially in smaller cities. It is there. Do we have any questions from the attendees?
None that I can see, but while we wait for more questions to pop up, I had a question for Professor Singh. Intra-arterial has given great results, but in groups A, probably A, B, C, and D. In India, the issue is at presentation, we see it's almost always at least 60 to 70% of the patients that we see are group D, group E, or even with orbital extension of the disease. So in India, for many patients, the applicability of intra-arterial chemotherapy is a little limited.
So that's a question of public health, so you really need to catch. So let's say intra-arterial has the best role for group group D. E, I think is very difficult. Group C, you can get away with intravenous. Although we don't have a head-to-head trial comparing one with the other, but I would say that in group D as in Delta, management of IAC preferentially better outcomes. But then again, D means diffuse vitreous seeding. You are adding intravitreal chemotherapy. You have to add. Intra-arterial will not take care of the vitreous seeding. So you can also get by with intravenous chemotherapy, add on top of that intravitreal chemotherapy, and for the residual tumor that you have left behind, you can do brachytherapy. So there's an alternative path that is accessible, cheaper, and I would say with less complications. But again, for group A, you don't need chemotherapy, you just need focal therapy. And for group B, you may get away just with focal therapy, or you may add intravenous. Group C, certainly you can also get away with intravenous. So you really have limited cases where this might be of advantage. Now, group E disease with neovascular glaucoma, group E where you see no disc or macula, that eye needs to be enucleated. There is no role of chemotherapy there. So if there's no vision potential, you're wasting your time, you're wasting patients' money.
True. Very often we, in cases where we advise enucleation, just to buy time, to allow the family to mourn the eye, we start off on intravenous chemotherapy. And in one of those few cases, you actually end up seeing a fairly decent response where you may actually salvage the eye. But like you said, those are very few and far in between. So you likely pointed out intra-arterial has a
I have two issues with that approach. Number one, chemotherapy isn't a tonic that you give and say, let's see if your cough goes away. Okay? Chemotherapy is chemotherapy and can have significant toxicity if it's not given properly, not monitored. For example, with carboplatin, you can have some issues with hearing loss, for example. So you'll not only have a blind child, you'll also have a child who can't hear. Think about that. So that's an issue with carboplatin. So you may say, oh, I want to avoid carboplatin. Etoposide, we know, can have some risk of leukemia. So there is a dose threshold below which you must stay. And the second more important point is that when you give intravenous chemotherapy and then you followed by enucleation, what histopathic risk factors you get are not indicative of the risk of metastasis. So you downgrade the pathology by partial response, and you cannot therefore infer what the risk is of the child of metastasis. So you are putting the child at a higher risk of metastasis. So that's a bigger impact. So plus, you're giving them hope. You're giving them some hope. Yeah, let's see if it works. But I don't think in oncology you should have that kind of approach. Let's see if it works. That's a totally, in my mind, inappropriate approach. You give the best approach first.
I agree with
know,
you.
So I understand the cultural pressures, but this is the barriers. You need to come around it. You can ask 3 people to advise the patient enucleation instead of just you. They may not listen to you. I say, okay, I have 3 other doctors. Let's see what they say, and have a panel recommended. So there are many ways around it, but to succumb to this that, oh, this is an easier approach. Let's see what, we'll buy time. I think you are just not doing service to the patient. That's my thought on it. Okay, thank you. That's an interesting question, and I can see why that might be happening.
Yeah, because in most cases, the patients end up not seeking any treatment at all, and having a child who then, with the natural course of history of retinoblastoma, ends up losing their life. So it's a little tricky. But yeah, I think you rightly pointed out, it's not something to be taken lightly, chemotherapy. Thank you.
So if there are no further questions, we can move to our next talk. That is by Dr. Richard Allen, Red Flags in Blepharoptosis. So you may begin your talk now.
All right. Thank you so much for inviting me. I really appreciate it, and really appreciate sharing the stage with such great people. Basically what I'd like to talk about today may be a little simple for the panel in particular, but I'd like to talk about red flags in blepharoptosis. And this is a particularly topical subject right now in the United States because we have a new drop that's on the market that goes by the trade name Upneeq. It's oxymetazoline. And basically, the company is really pushing for it to be used throughout the population for anybody with a droopy lid. And we've just seen horror stories of patients who have ptosis due to other reasons that have been missed. And so I'd like to talk a little bit today about particular red flags that we should pay attention to. I have no financial disclosures. So when we think about red flags, we think about diagnosis, treatment, and postoperative care. Today, I'm just really going to talk about diagnosis because we don't have time to talk about treatment and postoperative care. So when we think about diagnosis, let's talk about the obvious red flags first that I think all of us know and even our trainees know, in particular, anisocoria, motility deficit, or fatigability in these patients. So anisocoria, this is often detected by my technicians first. I'm very thankful for them because they'll usually put a big red mark on the chart or in the note that says anisocoria, and in a busy clinic, sometimes that can be difficult to see. So when we think about anisocoria, of course, that can be caused by either sympathetic or parasympathetic problems. I think most of us would not miss this, but in a busy clinic, it's possible that you could. So, both of these patients obviously have an ipsilateral meiosis and ptosis, and they both have a Horner syndrome. So it's important, of course, to work up any patient who has a Horner syndrome to make sure that there isn't anything else going on if this is acquired. So, looking closer at them, usually we're going to see a greater inequality in dim light as opposed to bright light. With regards to motility deficits, when we think about motility deficits, this could either be neurogenic, this could be myogenic, such as we see in chronic progressive external ophthalmoplegia, neuromuscular, as in myasthenia gravis. And then, of course, orbital processes can also cause motility deficits. So things to pay attention to. I think none of us would miss this obvious third nerve palsy. Of course, if this is something that's new, they're going to get imaged. Again, you're going to see the anisocoria with this, which is pretty obvious. Fatigability, though, can be sometimes difficult to elicit in patients. Of course, every ptosis gets worse at the end of the day. So when I think of fatigability, really, I want to see fatigability in front of me and then also variation in the ptosis during the day from the patient. It's always important to remember that new ptosis or a motility deficit in your thyroid patient should be worked up for myasthenia gravis because we see that quite often. So here I have a patient who comes in complaining of ptosis on the left eye. He tells me that there is, when he wakes up in the morning, it looks pretty good. As the day goes on, or even during the day, there's significant variation. I like to be able to fatigue these patients in front of me. And so I have him look up. And as we just go over just about a minute here, that eyelid closes. And so obviously myasthenia gravis, I take myasthenia gravis seriously because this is a potentially fatal disease. And I always tell the story of a patient that I had who I diagnosed with myasthenia gravis in the clinic. I said, you need to go to the neurologist to get this taken care of. He had hip surgery scheduled later in the week that he didn't tell me about. He ended up in the ICU after his hip surgery due to a myasthenic crisis. And he was not happy with me, to say the least, because I did not tell him of this potential problem. So again, I take myasthenia gravis very, very seriously. Here's a patient who came in and she has a ptosis on the right side, but thought that maybe she has a retraction on the left side, but this is actually a ptosis on the right side. She was seen at one of the medical spas here in the States and given botulinum toxin to see if this would improve her ptosis. Of course, it did not. And then as we look at her here, she has a motility deficit, especially in supraduction and AB and adduction. And of course, patient like this, we need to scan. We scan here, we see this orbital process, and she ends up having metastatic breast cancer. So again, important to image any of these patients where you cannot explain their motility deficit. Pseudotosis is one of those things that we think about when they have a low lid, but it's not really due to any of the traditional etiologies of ptosis. When we think about the traditional etiologies of ptosis, we're really talking about Bark-Free classification of aponeurotic, myogenic, neurogenic, or mechanical. So if they don't fit into one of those classifications, then we sort of consider it to be a pseudotosis. We'll see this with inophthalmos. We'll see this with facial nerve tonicity. So what I mean by that is synkinesis or aberrant regeneration after a facial nerve palsy. It's really important to take a look at the entire face. I always get on my residents for that when they're just looking at the eyelids, and I'm saying, just look at the whole face. Do you notice any asymmetry? Especially now with COVID, a lot of these patients won't take their masks off, and they shouldn't unless we have a good reason for that to be done. And so I will often have them take off their mask just to look at the symmetry of the face. And then, of course, also contralateral retraction can cause a pseudotosis. So we have a patient here who comes in with a ptosis on the left side. We take a little closer look at him and notice that he does have inophthalmos on that side. That can be tough to detect in a busy clinic again. And then we scan him and he has a silent sinus syndrome that has caused his inophthalmos. Here's another patient who comes in complaining of ptosis on the right side. And again, looking at her face and noting the asymmetry, in particular, she has a brow ptosis on the right side in addition. And then when I have her purse her lips, we notice that she has synkinesis of her facial nerve. So again, something very important to pay attention to in these patients. I think trying to distinguish whether a patient has contralateral retraction can be very difficult. We'll often have those younger patients come in early on in their thyroid eye disease who may have a unilateral retraction and they come in complaining of a contralateral ptosis. What I often will do is give them a drop of phenylephrine on the ptotic or supposedly ptotic side to see if there's any difference in the eyelids afterwards. Hyperglobus, again, can be difficult to distinguish. Hypertropia, though, should be relatively easy to figure out. But those are things that can look like a ptosis when they come into your clinic. With regards to concerns in children, always look for a Marcus gun. Always look for a lid mass, neurofibromatosis type 1, or seeing a plexiform neurofibroma in the upper lid, hemangioma. Of course, this is going to be acquired relatively early in life. And then with regards to blepharophimosis epicanthus inversus syndrome, we'll always be aware that there is this potential for premature ovarian failure in females. So Marcus gun jaw winking, again, this is about 4 to 5% of congenital ptosis. So I always ask the parents if they notice any difference in the lid height when the child nurses. And then I try to look for it, of course, myself in clinic. And so, ptotic, and then when they move their lateral pterygoid on that side, you notice that the eyelid, that the eyelid raises. And then also be aware that there is the possibility of a bilateral wink. So about 4 to 5% of Unilateral winks are bilateral. So here we just have a bilateral wink here. Now this patient comes in and you could say, gosh, you know, this is just a simple congenital ptosis, but be aware or be cognizant of that temporal droop, which should tip you off that this is actually a plexiform neurofibroma. And same thing with infantile hemangiomas. These are usually going to be acquired at the age of about 6 weeks or so of life. So blepharophimosis epicanthus inversus syndrome, I had a parent bring in this pedigree to me, and I love to look at this pedigree because when I look at it, you notice that any of the affected females do not have children. And so this should tip you off that this patient has a mutation that predisposes her to premature ovarian failure. And so this is something that needs to be brought up with the family, and I usually send them to the endocrinologist as well as the pediatric gynecologist to be worked up for this. Again, type 1 has this risk of premature ovarian failure in females. Type 2, no premature ovarian failures. Look at the pedigree. Ask if any of the affected females have had children, and that's pretty predictive with regards to whether you're going to have a problem. Acquired ptosis in children gives me a lot of anxiety. And, you know, when I have that 5-year-old that comes in and the parents say, yeah, lids were fine, and then just, you know, over the last few months, it's become droopy, you know, to me, that makes me very nervous. I usually require proof, though, that this was not present previously. So I want to look at previous photos in these patients. But myasthenia, I see a fair, you know, maybe 2 or 3 cases a year of childhood myasthenia, but malignancy in particular is what I worry about. And usually that's going to be with associated orbital signs. Concerns in adults, you know, early acquired ptosis, again, similar to children with acquired ptosis, adults with acquired ptosis early on makes me worried. I always ask about family history, looking in particular for any evidence of chronic progressive external ophthalmoplegia, oculopharyngeal muscular dystrophy, or myotonic dystrophy. Or sometimes, you know, this will just be sudden recognition. The patient will, you look at old photos and you notice that they actually do have some ptosis before. But in general, the history should make sense. You know, do they have a history of drop use? We do know that the use of topical prednisolone drops can increase the risk of ptosis, hard contact lens wear, trauma, chronic eyelid manipulation, previous ocular surgeries. We look at the basics, but again, don't rely on levator function on its own to drive your treatment. Think of it more as levator health. Look at the speed of the eyelid. Some other subtle findings: superior sulcus deformity, inophthalmos, floppy eyelid syndrome, prostaglandin-associated periorbitopathy. Always avert the lid. So again, relatively obese male that comes in with a droopy lid, this should sort of scream floppy eyelid syndrome to you, as we see in him. And then again, you know, an acquired ptosis, always avert the lid. I always tell my residents that eversion of the eyelid is part of the ptosis exam. She has amyloid actually under the eyelid. Lastly, you know, if these patients have ocular irritation, I would proceed with ptosis surgery with caution, if at all. I don't like to cause worsening dry eye in these patients or ocular irritation in these patients. But in the end, we really come back to the beginning. What do I mean by that? You know, these should fit the BART-free classification: aponeurotic, myogenic, neurogenic, mechanical. If it doesn't fit, you should reassess them. Thank you so much. Happy to take any questions if there are any.
So I would like to ask you your experience on tarsoconjunctival mullarectomy. How have been the results?
For a mullarectomy or with a tarsectomy?
First, tarsoconjunctival mullarectomy, and then I would also like to listen about your results of mullarectomy, only mullarectomy.
Okay, so I, you know, it's interesting because, you know, the history of what I would call a mular muscle conjunctival resection, an MMCR, first sort of developed by Alan Putterman. You know, in the United States, this went through an interesting history where it was popular in the 70s and then it was sort of disparaged for about 20 years. And then in the 2000s, people started using it more and more. I always tell my trainees that, you know, when I went through my training, i.e. fellowship and residency, I did 0 MMCRs. And the reason for that is that I was sort of brought up under what I would call the Rick Anderson rubric, in that, MMCRs were inappropriate surgeries to do. But, for the right patients, I do it, and I do it quite often now. I'd probably say that about 50% of my ptosis patients, involutional or aponeurotic ptosis patients, will get an MMCR. I like to see a response to phenylephrine. I will give them a drop of 2.5% phenylephrine, wait about 10 seconds, give them another drop, and then let the patient wait for about 5 to 10 minutes and see if I see a response. If I don't see a response, then I will not do the surgery. I like to see the response. I don't do traditional Fasanella savants. Okay, so like a Fasanella savant procedure where you take 3 to 4 millimeters of tarsus. To me, the reason I don't is that when you reoperate on those patients, it's very difficult. And when you go and do a reoperation, you see that someone has about 3 or 4 millimeter bridge of tarsus on their upper eyelid, and you're trying to do a levator advancement or resection or even a frontalis sling, that eyelid is very unstable. And so I personally do not do Fasanella savants. However, I will do lately, I have started doing a 1 to 2 millimeter tarsectomy in addition to an MMCR, but no more than 2 millimeters. And in particular, I'll do this for pediatric patients. I won't do it for adults because I don't see the justification for it, and that I can do a levator-based surgery and get a good result. But for children where they may have 2 millimeters of ptosis with pretty good levator health, they might respond a little bit to phenylephrine, but not completely, then I will add a tarsectomy in a 1 to 2 ratio for the amount of elevation I need after the phenylephrine. So what I mean by that, if they have 2 millimeters of ptosis and I get a 1 millimeter lift after phenylephrine, I might consider a 2 millimeter tarsectomy, but I will not do more than a 2 millimeter tarsectomy, just because that really puts me at risk, especially if I'm going to have to do a reoperation later. So that's my current approach, but in 5 years that might change.
Okay. And so one more thing, I saw in most of your patients, they also had an extra skin fold, extra lid fold, which was there in the form of blepharochalasis. So in those cases, how do you manage to get a good lid crease? Because what I have experienced is in most of the patients, even after the surgery, the lid crease is not very well formed, and they have a extra skin which is hanging over and giving them a look of pseudotosis.
So for a posterior approach ptosis repair, is that so are you talking about lid crease after posterior approach ptosis repair?
No, through the anterior approach.
For the anterior approach, okay. So in general, I will reform the lid crease, and the way in which I do my levator, my levator-based surgery is that I disinsert the levator aponeurosis from the anterior surface of the tarsus, and then dissect between the levator aponeurosis and the underlying Mueller's muscle, and then advance that aponeurosis to the tarsus, and then I will incorporate the edge of the levator into the incision at the end of the surgery, if I want a relatively strong lid crease. So what I mean by that is, lid creases are, they're probably some of the most important parts of, are one of the most important parts of ptosis surgery, because people will notice an asymmetrical lid crease more than they will a absent lid crease, in my mind. And so if it's a unilateral ptosis, I'm really careful. If it's a bilateral ptosis, I usually don't go overboard with regards to reforming the lid crease. And the reason I say that is, again, if I get any asymmetry, they're going to notice that more than if I just give them a relative, I wouldn't say indistinct lid crease, but one that isn't too strong. And so if I give them a really strong lid crease, I run the risk of giving them asymmetry, and again, having them notice that. So a lot of it depends on if it's unilateral or bilateral, and also what the patient's wishes are. But if it's a unilateral ptosis and they have a strong lid crease on the other side, I'm very careful with regards to how I form that. Does that make sense?
Yeah. And my second question in that was, how do you manage the blepharochalasis? Do you cut the extra skin which is hanging over?
So, if you're going to do it at the same time as a ptosis repair, then yes, I will do a blepharoplasty at the same time. And again, I think symmetry is the most important thing with regards to dermatochalasis management. People won't notice a little overcorrection as long as it's symmetrical, but if you have any asymmetry, again, that's important to pay attention to. So again, it's not how much anterior lamella you remove as much as it is how much remains, and so you just need to make sure that you have equal amounts remaining at the end of surgery. So, I'm not trying to take off the same on both sides. I'm trying to make sure that in the end, they have the same amount remaining. And so I'm very careful with regards to where I measure my lid crease, because I need to make sure that that's perfectly symmetrical. And then I need to make sure that the amount of tissue remaining at the end of the surgery also is symmetrical.
Thank you, sir, for answering all those queries.
I had a question if you have a minute.
Yes, sir.
You mentioned about myasthenia and how that's a red flag that we really should not miss in our clinic. But we know the ocular myasthenia doesn't often come up, positive when we get their lab tests done. I rely personally a lot on the eyes test. Is there a laundry list of tests that you get done? We get their single fiber nerve EMG, an anti-acetylcholine receptor antibodies, anti-musk. Do you get all of them done, or do you tailor it to which patient needs what? Yeah. Or do you give them a treatment trial based on what you think it is? Because oftentimes neurology, and we find ourselves not working in sync with neurology.
Yeah. I completely agree. It's a great question, because I think that if it's obvious myasthenia. So if they have fatigability in clinic, I don't care what anybody else says. That's going to be myasthenia. I don't care. I don't want to get the labs, because if the labs are normal, then I'm going to fight with the neurologist about whether this is myasthenia or not. So first I go to fatigability, and then if they have symptoms if they're ovulocitotic in the clinic and I don't get fatigability, I would go to an ICE test. If that is not positive, then I'll send labs. And if my suspicion is still great, I'm usually going to send them for single fiber EMG. But, that's going to be last. My suspicion has to be really high. Jeff Nerad, who I trained with, he said that the way he diagnosed myasthenia was after the reoperation. So, it is true. You have these patients come in and you're like, gosh, I did perfect surgery. They look great at the end of the surgery, and now they're droopy again. And then you realize, oh, they have myasthenia, and I never figured this out. But hopefully that's not our test for it. But realistically, I go fatigability, then ICE test, and then labs, and then single fiber EMG. But I don't do them all at the same time.
No, that's very helpful, because it's like they say, if you have a hammer in your hand, everything looks like a nail, because every ptosis patient who's gone to a neurologist comes back with a treatment prescription for myasthenia, even though it's congenital in some cases. And you're like, why would they want to do that? But right. I think a step ladder pattern, I agree, it makes a lot more sense. Thank you so much.
Thank you.
Just to add one thing, Rick, about skin creases, to add to your importance of them. One thing that we sort of learned over the years was, if you want the patient to look brighter-eyed than you dare raise the lid, deliberately try and set a slightly low skin crease, skin fold, that is. Whereas if you want them to look not so bright-eyed, set the skin fold higher, and so you can use that in difficult cases where you're a bit worried, like a partial third, where you may have a problem with exposure and so on. And it's a useful trick. So you can use the skin fold quite a lot, as you so rightly say, and getting it right. You're absolutely right. They notice asymmetry more than absolute level. Most of us are wonky, but you get a wonkiness you're used to. And it's when you change it that they suddenly notice.
No, absolutely.
Great talk.
Thank you.
Do we have any more questions now?
No, I can't see any in the QA box, so I think we can move on then.
So if there are no further questions, we can move to the last talk in this session, that is by Professor Rose. Sir will be discussing about his 30 years of experience in managing the lacrimal gland tumors. So so you can start sharing your screen.
Professor Rose, if you're speaking, you're on mute, so you may want to unmute yourself.
Thank you for reminding me. We'll see if I can make this share properly. I hope I'm turning blue.
Yes, you are.
Good. Excuse me. Try and make it full screen and remove some of this. Excuse me. It takes a little while to get things moved out of the way. And so thank you very much to everybody at the Society for kindly asking me to speak. And I thought I'd update us a wee bit on lacrimal gland carcinoma, because it's a lesson that I started learning more than 30 years ago. And I'll explain how I learnt what we were doing. I have no conflicts of interest to declare. As many of you will know, the natural history of lacrimal carcinoma is this sort of relentless progression from a relatively small lesion, when you may get a more obvious signs with some impairment of motility or so, or then you may start getting congestion of the orbit as it invades more posteriorly, and then it may take over the globe. And similarly, the radiology may be a relatively well-defined tumor, more extensive disease molding around the globe, and it typically runs back between lateral rectus, what we've termed the triangle sign, runs back along the wall. It has this propensity to do so and go into the superior orbital fissure. Then, of course, you get a tendency to destruction of the lateral orbital wall or the middle cranial fossa, and finally, major destruction of the skull. Historically, lacrimal carcinoma really had a poor prognosis, relatively poor prognosis, and only about 30% of patients would survive, and that's based on our paper from 30 odd years ago. And so this was what it was like when I was an early consultant, really not a very good outlook, a tumor of young people. And the poor prognosis that this had at the time encouraged us to do cranioorbital surgery with resection of the walls and so on. But when we looked at the data 30 years ago from the previous sort of 20 years of treatment, basically we found that cranioorbital resection and local resection and radiotherapy did more or less exactly the same survival. And so when I looked at the patients, we found that cranioorbital resection did not reduce the rate of recurrence, non-significant. But this hides the point that the patients that we sent for cranioorbital resection at that time were considered to have locally curable disease, i.e. within the orbit, and that's why they had cranioorbital resection. Whereas those patients with tumor outside the orbit were regarded as incurable and were sent only for radiotherapy. So these were regarded as beyond surgical cure, the patients who had radiotherapy, and yet they did as well as those that had major surgery. And they really did almost identically. And in the early paper 30 years ago, I suggested that in fact, local resection of the tumor might be as effective as cranioorbital resection with radiotherapy. But we really do need to follow it up and find out what's happening. So what was the trouble with cranioorbital resection and what was happening to these patients? Well, the patients from the 80s and 70s, what we saw was that they'd be all right for a while. So here's a patient about 7 years, but beginning of recurrence, but they'd done pretty well. And then over the next 2 or 3 years, they get ever worse recurrence of the disease with involvement of the calvarium, the skull and so on. It would just take over and eventually they would die from metastatic disease. And it was a horrible death. They were often young people in their late 20s or early 30s, and they just relentlessly be invaded by this tumor. So at that time I thought, look, should we really be disfiguring these young people if it doesn't help the survival at all? Should we be taking half their head off? And so in 1992, literally 30 years ago, I took the decision to stop referring patients with lacrimal carcinoma for craniofacial resection. So what did I do instead of the craniofacial resection? Well, I would perform urgent transcutaneous biopsy within the week to find out what was going on. And again, once that was proven to be carcinoma within the week, I'd explore through the same skin crease incision, dissect the plane between the normal orbital tissues, or macroscopically normal orbital tissues, inframedially, and the lacrimal gland. And I'd use the monopolar loop electrode, the Elman loop electrode. I have no financial interest in it. And you can use the 6mm loop to resect the tumor right back to the superior orbital fissure. And then I'd send them for external beam radiotherapy to both the orbit and the cavernous sinus because of the problem of perineural spread. And so here, for example, is a young lad. He'd been offered the chance to have half his head off, and he came for a further opinion because he knew of the work or read of the work that we'd done, and has a relatively well-defined tumor, but has been proven, somebody's already biopsied and showed it to be adenoid cystic carcinoma. And so what we would do is literally through the upper lid skin crease, go down and separate the relatively normal orbital tissues from this abnormal tumor mass, which macroscopically can be quite well defined and go a long way back, and literally cook and diathermy and separate all the way around the tumor. And then once you've isolated the normal tissues, I'd use the Elman loop electrode to resect. And that leaves us tiny shell, which you can separate off from the bone. This is the external surface where it was against the bone, and remove that. In other words, macroscopic resection of a huge amount of tumor along, and it leaves a clean surface. Yes, microscopically, it may well be involved with tumor, but there's no macroscopic tumor left. And here he is within the week of surgery. And early on results from 92 onwards were encouraging. So this patient actually had involvement of the dura of the anterior cranial fossa at the time I resected. I had a CSF leak whilst resecting it. But here is the same patient 5 years later with no evidence of tumor recurrence, having had radiotherapy to the orbital roof, skull base, and back to the cavernous sinus. So things looked encouraging. But my 1992 decision to avoid cranioorbital resection, was it justified? Had I just made one huge mistake? In particular, I wanted to know, had I caused more deaths? Had I caused earlier deaths, even if I wasn't causing more? And the third thing is, was I causing more in the way of local recurrences by not resecting half the head? But the trouble is, the adenoid cystic carcinomas and lacrimal carcinomas have this propensity to late recurrence between anything up to 10, 15 years after the primary surgery. And so any series reporting results before 10 years is rather misleading. And so I really carried on doing this because they seemed to be doing well, but I wanted a 25-year follow-up on the earliest cases. And so we looked at them in about 2017, 18, and there were a fair number of patients. We wanted at least 2 years of follow-up unless they died earlier. We were able to track them down through the National Death Registry as to how they died and what they died from. And we had about 79 patients in the series which we could come look at. And it was the typical sort of mixture of adenoid cystic, adenocarcinoma, and malignant mixed tumor. And some had cranioorbital resection, some had debulk and radiotherapy, and a few of the very early patients had only radiotherapy. So looking at the three questions, had I caused more deaths? And overall, if you look at the overall survival and the disease-free survival, and remember the original series came down to about 30 to 35% survival. So in all the patients, they actually appear to be doing somewhat better. So something has shifted them up. Maybe the radiotherapy has improved since then. So no, we're not causing more deaths, if anything, less deaths. Was I causing earlier death? Well, if you actually look here, and this is the cranioorbital resections and the debulk and radiotherapy group, if anything, they are doing somewhat better. It's not so statistically significant, but there's a definite trend that they're not doing any worse. And the original suggestion that cranioorbital resection may have no benefit is strongly supported by this. Radiotherapy alone doesn't appear as effective as debulk and radiotherapy. So was I causing earlier deaths? Again, the answer is no. So I was starting to feel a bit happier after 25 years. It didn't look as though it was one huge mistake. Last of all, I wanted to look at, had I caused more in the way of local recurrences? Because you might expect there to be greater local recurrence, but the disease-free survival in relation to the mode of therapy, if you look, is almost identical again in the two groups. You know, P is 0.92, so they literally follow the same pathway, whether you take off the orbit or the orbit plus, or just debulk and give radiotherapy. So it looks as though the determinant for survival is not related to local disease, and they don't have an increased rate of local disease. In fact, the local recurrence following debulk and the radiotherapy is distinctly rare. So thank goodness the answer to all three turned out to be no. And what about preserving the eye? As I say, I suggested doing it back in the early 90s, and it was taken up by several groups, and I think findings have been similar. Basically, we had 67 patients who kept their globe. 3 out of 70 of them were removed either for pain or because of severe corneal perforation. Most of those were within 3 years of the hefty radiotherapy. So if they keep it for 3 years, they're unlikely to lose the eye. May not be the world's most comfortable eye, but many of them preserve pretty good vision. And the median overall was about 624, 630. And 50% of the group were able to have an acuity of 624 or better, some of them improving up to 6/6 after their cataract surgery. So really, in summary, what do we have? Well, lacrimal carcinoma patients do appear to have a somewhat better prognosis than they did 30 odd years ago. Overall, a half or so will survive long term. And of those, about 8% will have some disease. Cranioorbital resection really, it should no longer be regarded as the appropriate treatment for most lacrimal gland carcinomas. It doesn't improve the survival. It doesn't reduce the rate of local recurrence. It tends to cause the recurrences within the calvarium by seeding of tumor cells into the cancellous bone of the calvarium. So I strongly discourage it. It seems that macroscopic tumor debulking, leaving a clean cavity and adequate radiotherapy, in other words, 55 gray plus, seems to retain a functional eye in many cases, with a good number having really quite useful vision. Problem of dryness is a problem, but most patients find the value of the eye better than the discomfort. We know that survival is best with malignant mixed tumors and worst with adenocarcinoma. And this sort of confirms older studies. And probably looking at our long-term figures, having followed them for up to 25 years in both in the older group and the newer, it does look as though the line really flattens beyond 15 years. And you can probably regard 20 years as a cure. And here's a paper if you're interested in reading it, because it really is a major change in the way we should think about lacrimal gland carcinoma. So thank you very much, everybody, and thank you for the opportunity to talk at the meeting and some fascinating talks. Thanks. Any questions, really?
Thank you, Professor. Yeah,
Can I-
sure, Professor Singh, go ahead.
Jeff, this is wisdom, and only somebody who has long experience can talk the way you did your presentation. But it's hard for a patient to wait 20 years to know that I'm cured. And this is interesting because there
Yeah.
is a push in oncology in general, and now coming into ophthalmology as well, is about time to cure concept. So we are trying to apply
Yeah.
that for uveal melanoma. When do we
Yeah.
say I'm cured? So in retinoblastoma, we know from the COG study is 2 years. If nothing happens after enucleation in 2 years, you can take it as cured. So this is important when you design a study. If you have 2-year follow-up, that's sufficient because time to cure is 2 years. So in
Yeah.
your case, waiting 20 years is difficult, but what you could do and ask a statistician, or we can help you to calculate conditional survival. So if you cross 10 years already, what's the likelihood that you'll be
Yeah.
20 years?
Probability.
It's
Yeah.
probability, right? And
Yeah,
longer
yeah.
you survive, the probability increases of
Absolutely.
survival further. So at
Yeah,
10
we
years,
could calculate that.
exactly.
Yeah.
Very easily. So
Yeah.
you say, oh, you passed 10 years, 10 years is as good as 20 years, so you are cured. So you can, for patient cure, patient's counseling purposes, you can kind of bring it closer and you say, hey, if you cross 10 years, you're as good as 20 years. So we calculated that for uveal melanoma, and we say instead of 25, we say 15. 15 if you cross melanoma, uveal melanoma. You're statistically.
Yeah, you could probably say the same for adenoid cystic, probably. The trouble is it's the few that do it beyond 10 years. As you know, it can remain silent for quite a long time, and then bam, it reappears.
Yeah.
But I think you're right. We could probably increase the predictability by modeling on, was the bone pitted?
It's called conditional
and other
survival.
factors. Yeah, yeah. No, I'm sure you're absolutely right. Because on the other hand, if you do reach 10, 15 years, the answer is keep on partying. You know,
Anyway,
but it's very difficult. It's a lousy condition. The number of patients I've treated, you know, and you lose people of 23, 24. I remember a young mother, and they die from metastatic disease. You try chemo, you try cisplatin and so on. You know, maybe David sees intra-arterial work, but we can't really, we haven't got the facility for doing it. Might improve local control a bit, but you raised the very interesting point in your talk that you may actually conversely reduce systemic control. And as I mentioned, the patients that died, and I think I should look probably more closely at them, the patients that died from adenoid cystic carcinoma, all of them died from pulmonary disease. They occasionally will get a bit of calvarial recurrence just in the dura. They didn't get the terrible recurrences we used to, you know, where it's just spread along the dura, and you give them more focal radiotherapy, but they die. The big disease is all in the lung, not locally, interestingly. And so we are altering the picture, but we haven't cured it yet. A bit like your talk on retinoblastoma, you're absolutely right. It's a changing picture.
I just say that statistically you're cured, statistically, that's all. I don't say very likely, I just say based on statistics, you're cured, but we still have to observe. But that just gives them some comfort, basically.
Yes, well, yeah, no, I mean, it's like dealing with all patients with oncology. You've got to be straight with them. But there are ways of being straight. You know, you don't want to give them misinformation.
Right.
But at the same time, I'm sort of renowned as a cheerful optimist. You know, as you don't tell them you've got a 50% chance you're going to die. You say that this is a really lousy condition. The treatment is going to be pretty mean and the eye will feel pretty rough during it. But at the end of the day, we know that we can hit at least 50% of people who will still be playing in 20 years. And like yourself, it's just presenting it in a lively fashion. And if you can get the patient leaving the clinic with a laugh, you know, and saying, I'll come back, you know that you're on a sort of winner, not necessarily with the disease, but in looking after a patient, a soul, rather than a condition. And you stressed that, which was very good. I completely agree. Absolutely agree. Thank you.
Right. So, Dr. Singh, that was a bit of wisdom from yourself as well. Years of experience there. Dr. Rose, I wanted to ask you, in terms of a complete metastatic workup, what are the things that you would look for? What tests would you routinely advise? And what is your period of interval at which you would follow? And with time going by, do you increase the interval between their visits, or do you want them to come on a fixed number of months between visits?
Yeah, I mean, yeah, actually, a very sensible question. The initial workup, the majority of lacrimal gland carcinomas will not be detectable systemically. So that we will arrange, bone enzymes and standard blood tests, and possibly, if it's a huge tumor, arrange PET or a systemic CT. But in general, they're not. They tend to be rather more localized. But obviously, you will see a broader spectrum of disease and probably some pretty massive lesions. Certainly I have, from, as big as the head almost. But that's getting rarer. After treatment and the radiotherapy, what we tend to do is get a baseline scans at about 9 months to a year. By then, the acute edema will be settling down. The bone changes, which you may have seen, fine pitting or otherwise, often have settled down. It's often a periosteal reaction to what's going on, will have settled down. So you'll have a very good baseline CT for the bone. And MRI, if you are interested in what the Jura is doing. Key to get that baseline at about 9-12 months. And then we tend to follow them up clinically about 6 monthly for 5 years, with repeated imaging every year or two. Obviously, if there's any clinical indication, do it earlier. Most of them will be enophthalmic with a deep upper sulcus. And if there's any suggestion they're losing the enophthalmos, or the upper sulcus is filling out, just smell a rat. There'll be a tumor, starting again. But otherwise, and then after that, after about 5 years, we follow them annually long term, and we'll see them as necessary. And re-imaging, we tend not to. Beyond 5 years, it's a bit like Aaron says, maybe we're missing them, but it's a question of how many, how many patients do you irradiate at regular intervals for an ever decreasing value. And if there's only 1 in 20 will present after 8 years with a recurrence, probably it's not justified to irradiate 19. They've already had a dosage of radiation. I don't know what Rick or Aaron feel, particularly Aaron with his much broader experience of. You're muted, Aaron.
I don't have much experience with cystic carcinoma, but this also applies to other cases. I think some of it is patient-driven, and younger patients are obviously more concerned. If you have a 70-year-old, 85 years old, they may not be concerned so much. So it all depends upon patients.
An MRI, of course, will reduce. MRI will reduce the obviously avoids the radiation problem. But often we find that the quality of images of MRI, the patients fidget. It's very hard to, even with 3 Tesla machines, it's very hard to get quite as good a quality as you get with thin slice CT. I'm sure you probably find the same.
So I don't have specific experience with adenocystic carcinoma, but whatever you said makes sense.
But other forms of oncology, often we find MRIs often are just not as informative as we might have liked, but that's life.
One thing I would add with regards to the uncomfortable eyes, that I've had patients really do well now with scleral lenses, whereas before, it was the sort of, I was going to give them a tarsorrhaphy. It's like either I give you a tarsorrhaphy or you just pour drops on your eye. But scleral lenses have really sort of changed my life with regards to the treatment of these patients. Discomfort. And so I send them early on, because I've taken their lacrimal gland. They're going to obviously have aqueous tear deficiency, significant aqueous tear deficiency. And so, a scleral lens really helps them out a lot.
Yeah, well said, Rick. Yeah, there are a couple of things in relation to the dryness. I now always permanently occlude the puncta, the canaliculi, at the time of resection of the mass. because universally they will get quite significant dry eye, and that helps a lot. You know, if you, in the past, I didn't do it until they had problems, and these poor patients were putting in drops every half hour, you know, even though they were preservative free, but it would drive them crazy. Afterwards, you tend to find that they can get away with 4 to 6 times a day. You know, it's a significant difference from their point of view. And as you say, contact lenses, we used to be able to get silicone contact lenses, but we have a chap who actually makes gas permeable scleral lenses, not just fenestrated, but actually made out of the gas permeable materials with the appropriate power in them. And they are very useful because they also help the enophthalmos, the slight enophthalmos. And so you're quite right, anything that helps these patients, well, they actually do pretty well overall. The majority keep the eye.
Yeah, I agree. You can take that little bit of discomfort from them. You know, that's what is driving their life, is this ocular
Correct.
irritation, and you know, more so almost than the fear of recurrence.
Yeah, no, you're absolutely right. They're young people and they want to get out and about. So discomfort is a major disruption to life. And so anything that helps that is well worthwhile. And the other thing is, if they start getting pain, trigeminal pain, think recurrence, and keep chasing it with the appropriate high resolution MRI, because some of our patients do eventually get posterior cavernous sinus or second division trigeminal extension. Very rarely will you get it in the first division, but second division going down from, you know, in the pterygopalatine fossa. I've just had 1 or 2 have done that. Again, possibly just outside the primary irradiation area. It's already down in the second division. So if the patient gets neurogenic pain, think this is recurrence until proven otherwise. You know, an important key message with lacrimal carcinoma.
And then with regards to your metastatic surveillance,
yes,
you know, chest, abdomen, pelvis, are you doing CTs? How often do you?
The honest answer to that is I don't know for sure, Rick, because they go to a systemic colleague who deals with them. So, you know, I just get the thing back that they're doing all right and they've had this, or they've had a PET, or they've had a abdominal. But in general, it'd be interesting to look at the patients that recur, the sequence they recur. In fact, I may get one of my residents to do that, or fellows, because we've got enough patients with recurrence to actually work out what pops its head above the parapet first. And that would be helpful because it's not such a common condition. And, you know, but with 40 odd patients who've recurred, then it's worthwhile looking at how they stick their head above the parapet, as I say. Time will tell. Akshay.
Yeah, Professor, I had a question. We, you know, traditional teaching used to be, if there's a tumor, you would want to keep the periosteum. If there's a lacrimal gland tumor, you want to keep the periosteum intact. That is going to be a barrier that you don't want to breach, because that is sort of protective. Also, try to get the tumor in toto as a single piece. But you know, your surgery technique that you've shown is, it doesn't matter whether you take it out in a single piece, or you scoop it out, you cauterize it. Just make sure that it's out. How do you think that, I mean, you have the results to show that it works. So just trying to, you know, make sense of it.
Again, a very useful question, because the answer is, if it's a well-defined tumor, I will take it out intact without doing a lateral orbitotomy. The risk problem is opening the the cancellous bone. Cortical bone is the main resistance to tumor invasion. Periosteum is involved in all of these carcinomas. You know, so it's like a pleo. If it looks like a pleo, take it out. And I've just submitted 100 patients, in whom 54 of them we took out through lateral, and 46 or so we took out through anterior. All of them were well-defined orbital lobe tumors. 17% turned out to be malignant mixed tumors, but those patients did almost as well they really do extremely well, much, much better than adenoid cystic, even though they've had adenocarcinoma or adenoid cystic within the transformed Pleo. So the intact excision, you're absolutely right, go for it. The ones that I'm talking about, so if it's well defined, I'll take it out intact. The ones where I use the Elman loop are like that lad, where it goes right back to the fissure, and you're dissecting a macroplane. It forms a macroplane, literally a triangle, a wedge going back to the apex of the orbit, what we call the wedge sign or the triangle sign. We wrote it up in ophthalmology 5 years ago, something like that. You can literally dissect it out as an en plaque, and then we just use red hot wire cautery. I mean, it's blazing, the smoke comes out. So anything that touches is turned to charcoal. So the cut edge is being sterilized as you work, and you can literally shave it out right back to the fissure. I mean, you'll just literally have the muscles there, the superior fissure. You can get right to the annulus. And that seems, as I say, to control the local disease. Local recurrence in the orbit is distinctly rare. The recurrences tend to be remote from the radiotherapy local area. So the technique seems to work, but you're absolutely right. Take it out intact if you can. It is macroscopic disease, so you do have to treat the microscopic periphery. And, no amount of resection will do that. And what we've shown is taking the whole orbit out doesn't actually help stop that problem. So, spot on. You're very accurate in what you say, but you sort of tailor it according to the extent of the disease. Thank you.
Thank you. Dr. Gunjan, if we have any more questions from...
No, I think I don't see any more questions coming in. So
maybe it's all just us listening, which is all very nice, because it's actually quite fun, having a really good opinion from, colleagues from around the world. It's always lovely.
Yeah, I was going to add to the use of monopolar cautery in tumor destruction. I think it works.
Yeah.
What you're talking about with regards to, I mean, I do that, if I have, the rare exoneration, that I will do, I really cauterize the apex, down to bare bone, down to the fissures. I'm always worried I'm going to cause a CSF leak, but I mean, I think it's I don't have any proof, but it's interesting to hear your experience with it in the use of the monopolar cautery to really destroy any potential residual disease.
Well, it's interesting, and I'm sure you've seen it with resection of lid tumors. You have them, and Aaron certainly will, and many of you will have seen, they report on the specimen that tumor cells come up to the margin, and so on further sectioning. They missed them, or they just didn't, the section didn't pick them up on cryo, on frozen section. But what you then go back, you resect the original line, and there's not a tumor cell in sight. And that, as you say, is a mixture of thermal destruction at the old tissue edges, plus cytolysis. Every cell you kill invites in a few of Mother Nature's hand grenades. In other words, neutrophils, non-specific, releasing shrapnel, i.e. cytokines and cytolytic enzymes, which damages the cells in that neighborhood as part of the healing process. And so no wonder, even though tumor cells do come to the margin, it doesn't necessarily mean that they'll still be there after the healing process has occurred. So you're quite right. You can use damage to cells as a way of killing cells.
Now, I've always thought that cryo helps us in that way also, because cryo kicks up a tremendous immune response. Yeah. And I've always thought that cryo is sort of our local immunotherapy when we apply it.
Yeah. Yeah. Well, the status of immune response and melanoma is one of those great things which Aaron will know far more than I do. But, I always remember Richard Collins saying, you can have conjunctival melanomas recurring again and again, small ones on the ocular surface, conjunctival fornix, and then suddenly at about 20 years or something happens, or 15 years in the patient's life, and it takes off berserk. Now, nowadays, probably Aaron will say that's a genetic change, because again, he knows far more than I do. I'm just a simple, chop them easily man. But it is interesting that something can alter the pattern of disease after donkey's years. You're still muted, Aaron. You're too good to mute.
So patients, I'm talking about, say, PAM with conjunctival melanoma. You treat the PAM with cryo, mitomycin, whatever, and they're stable and stable and stable, and then bang, there's something, and then you remove it, and next they have more aggressive disease. So they do take off. What triggers it, we don't know. But
yeah, Richard always used to think it was immune related, but I just wonder, in fact, whether it's genetic related.
Yeah, I think
who knows?
For melanomas, not so much immune, but for squamous cell carcinomas, there is a lot of immune things we know, but not so much for conjunctival melanoma.
Yeah.
Squamous cell carcinomas waiver with immune system, HIV, things like that. We know that.
Absolutely. Yeah. Yeah. Surveillance. Well, that's.
So as you are talking about conjunctival melanoma now, I would like to ask you what has been your experience in using interferon drops instead of mitomycin C for conjunctival melanoma cases?
That's for you, Aaron. I've never done any of that. It's far too clever for me. I'll switch off.
I don't use them, and I don't know what the biological basis is for suggesting that they might actually work. So what mechanism you think will be involved in controlling melanoma using interferon drops? I don't know. So they have not used it, no.
Okay.
So even so, drops, topical therapy, even mitomycin is not effective for melanoma. It's effective for PAM with atypia or melanoma in situ.
Mm-hmm.
The moment you have conjunctival melanoma, treatment is surgical or brachytherapy.
So why doesn't it work for melanoma? Why doesn't it work for melanoma, Aaron? Because the cells must be sensitive, or is it just the thickness of it? It's too thick. You're moving into the invasive phase, a bit like, squamous carcinoma in situ, moving into an invasive phase.
So all this topical therapy is effective for in situ.
Yeah. Yeah, you need a single cell.
The growth is in the stroma below.
Yeah. It's invasive.
Only on the surface.
Yeah, once your basement membrane is penetrated, you can forget it. Yeah, and that's the big mistake, that people get into the mindset of drops for things like sebaceous carcinoma. And yes, the ocular surface looks a million times better because of the sort of pagetoid spread is treated. But what they overlook is the invasive component. And you may have seen the paper we put out on that we showed invasive or pagetoid spread right into the lacrimal gland, so much so that in one of the patients, it went through the gland and right out. There was pagetoid spread right out to the periosteum, the periosteal surface. So even when you've only got pagetoid, you still can't treat it necessarily with drops alone. Topical chemo is a useful tool, but it's not a panacea.
Yeah, and only for in situ disease or preneoplastic. If you say somebody is CIN, dysplasia 2, okay, so that's not really fully neoplasia, it's dysplasia. And those kind of things, it will all work very nicely. But anything invasive, no.
Yeah, absolutely. Or anything not on the ocular surface. So, for example, as I say, the pagetoid spread, it was still in situ disease, but it was actually along the ductules all the way out to the periphery of the gland. It was a spectacular. We couldn't believe it when we saw the path. So, look, so we solved the whole world. Not really.
I think so. It's time to enjoy the rest of the morning or the day. Thank you so much for inviting.
Yeah,
pleasure to talk to all of you.
Yeah, thanks. Yeah, super. Great to see you all. All the best.
Yeah, great to see everyone. Thank you again for the invitation.
Yeah,
really
thank you.
appreciate it.
Thank you.
Yeah, it's good fun.
I just want to say I'm Dr. Mandeep Bajaj. Dr. Arun has been supporting our oncology setup at RP Center at the All India Institute of Medical Sciences. And it's really great to see him here. And Dr. Rose And
Thank you.
Dr. Allen, I mean, such a wonderful, experience to have such a distinguished panel. And the fewer the speakers and the more discussion we could have, it was really wonderful. And there was a lot of resonance in our minds with what you said, especially Dr. Allen raising the red flags and not to just brush a very subtle sign under the carpet. I mean, the signs are usually staring at you right in front of you and you tend to miss them. So that was very good. And Dr. Rose's flamboyant style of his humor and his, that was really wonderful. And I really wish that I really thoroughly enjoyed myself. Yeah, thank you so much for this. Thank you.
Thank you, Prof. It's it's been great fun, and thank you, everyone.
Thank you.
Thank you, everybody. Good night.
Thank you.
Bye-bye. Thank you so much.